So, Dr. Dwaram, kindly please proceed reading the question.
Yeah. So a 64-year-old woman is admitted to the emergency department with cough, pyrexia, and confusion, which has steadily worsened over the past 24 hours. She has hypertension for which she takes 2.5 milligram of benzoflumetazide each day, but is otherwise well. Her temperature is 38.2 degrees Celsius and her pulse is 89 beats per minute and regular. Her blood pressure is 159 or 85 millimeters of mercury. She has crackles at the right base on auscultation of the chest. Her Glasgow Coma score is 13 by 15. Investigations, hemoglobin 11.7, white cell count 13.4, platelets 203, sodium 121, potassium 4.9, creatinine 120 micromoles. The question is, which of the following is the most appropriate intervention for this patient's hyponatremia? Demeclocycline, fluid restriction, ibuprofen, 0.9% saline, or 1.8% saline.
So, based on the scenario given here, this patient has the features of consolidation or pneumonia, and the patient has also come up with the features of with the hyponatremia. The sodium level is only 121, and there is also history of taking the thiazide diuretic. So, just looking at the picture, features of hyponatremia in the lab pictures with the features of consolidation or pneumonia. So the most likely diagnosis here should be the SIADAs, syndrome of inappropriate ADA secretion. So what should be the most appropriate intervention in case of SIADAs? And just look at another thing. The patient's blood pressure is elevated and there is no
Yeah.
renal impairment here. So this further suggests the diagnosis of SIADAs. And since the patient isn't hypovolemic and the patient doesn't have the renal impairment, so the 0.9% normal saline won't be needed here. So the most likely treatment here should be the fluid restriction.
Fluid. True.
Yeah, exactly. The fluid restriction should be the first line and the most appropriate management in order to treat the SIADs. And still, if the patient doesn't respond well, then demeclocycline can be given as a second line option. And 1.8% saline or 3% saline, they are known as the hypertonic saline. They are indicated only if there is severe hyponatremia, and that hyponatremia should be symptomatic. Either there should be features of seizure or the GCS should be very low here. Can anyone tell me the gradings of hyponatremia? Gradings?
Yeah, less than 120 is severe, 120 to 129 is moderate, and above that is till 135 is mild.
Okay, just look at here. The severity of hyponatremia when the level is in between 130 to 134, this indicates mild hyponatremia. When the level is in between 120 to 129, it's moderate. And when it's less than severe, it should, when it's less than 120, it should be severe. And this severe hyponatremia, when comes up with the severe symptoms, then it should be treated with the hypertonic saline, mostly the 3% normal saline. So acute hyponatremia with severe symptoms, meaning the level should be less than 120. Patient with acute severe less than 120 millimole per liter or symptomatic hyponatremia requires close monitoring, preferably in the HDU or in the above setting. So you'll have to treat the patient either in the HDU or in the ICU. This type of patient can't be managed in the normal ward. Hypertonic saline, typically 3% normal saline is used to correct the sodium level more quickly than would be done in patient with chronic hyponatremia. So usually the hypertonic saline is more commonly used in a patient with chronic hyponatremia. But if the patient develops severe symptoms like features of seizure or there is very low GCS, then in that case we will have to go with the hypertonic saline, 3.3% normal saline. And in case of SIADs, the urinary sodium level should be greater than 20 millimole per liter. But in the question, the urinary sodium hasn't been mentioned. But if it was mentioned, then the most likely the urinary sodium should be greater than 20 millimole per liter, and the urine osmolarity should be greater than 500 millimole per kg. And in case of psychogenic polydipsia, the urinary sodium should be less than 20 millimole per liter, because the patient will be taking so much water. Ultimately, there will be hypodilution of the sodium electrolyte. So here, features of SIADs with elevated blood pressure and no evidence of renal impairment. So the most likely treatment here should be the fluid restriction. So this patient has hyponatremia, probably as a result of a lower respiratory tract infection combined with chronic use of bendrofluoromethazide. That thiazide diuretics is also associated with some sort of hyponatremia. Given her blood pressure is elevated and there is no evidence of renal impairment, fluid restriction is the most appropriate initial intervention. And NSAIDs are the treatment for the nephrogenic diabetes insipidus. Okay, let's look at the treatment of nephrogenic diabetes insipidus, stepwise management. So the first step would be to go with the low solute diet. This is the first step. And after giving the low solute diet, for the second step, we'll have to use the thiazide diuretics. And the traditional one is preferred in case of nephrogenic diabetes insipidus, and the traditional one is the bendrofluoromethazide. And the third step would be to add the NSAIDs. And they are the add-on therapy. For step 1, give the low solute diet. For step 2, give low solute diet plus thiazide diuretics. And for step 3, low solute diet plus thiazide diuretics plus NSAIDs. And among the NSAIDs, indomethacin is preferred compared to the naproxen. So you'll have to give the indomethacin, not the naproxen. At 1.8% normal saline, this is only considered as a treatment of life-threatening hyponatremia when the patient has a severely decreased consciousness level or is suffering from the seizure. Okay, next one.
Can I continue?
Yeah, please continue.
Okay. Which of the following is the most appropriate intervention for control of his bone pain? The options are external beam radiation therapy, increased oral morphine, intravenous zolidronate, strontium-89 therapy, and transfer to fentanyl patch. The question is, a 74-year-old man with metastatic prostatic cancer who has extensive bony metastasis is reviewed in the palliative care clinic with respect to his pain control. He currently complains of pain in his lumbar spine, both femurs, and his right humerus. Currently, his medication includes anti-androgen therapy, morphine 80 milligram twice daily, paracetamol 1 gram 4 times daily, and ibuprofen 400 milligram 3 times daily. He also takes medications for nausea and constipation. His blood pressure is 145 over 90 millimeters of mercury, and his pulse is 85 beats per minute and regular. His body mass index is 23 kilogram per meter square. Investigations: hemoglobin 9.8 grams, white cell count is 10.9, platelets 231, sodium 144, potassium 5, creatinine 132, calcium 2.3, and glucose 8.1. Which of the following is the most appropriate intervention for control of his bone pain?
So this is a case of metastatic prostate cancer, and there has been extensive bony metastasis. So at first, let's see the treatment for prostate cancer itself. Can anyone tell me the name of the drug for metastatic prostate cancer? Which drug is used?
Morphine.
No, I was asking about the definitive management. Morphine can be given for the control of bone pain or for the control of pain. Okay, just look at here. For the management of prostatic carcinoma, whether this is isolated prostatic carcinoma or metastatic prostatic carcinoma, for the definitive management of prostatic problem, at the first line treatment should be the goserelin, and the second line treatment should be the enzalutamide. And can you tell me the mode of action of goserelin?
LHRH
Yes,
antagonist.
very good. Goserelin is the luteinizing hormone releasing hormone analog, and the enzalutamide or the bicalutamide, they are the ARB, androgen receptor blockers, and they are the non-steroidal. I'm showing for the goserelin. Just look at here, goserelin. This is the luteinizing hormone releasing hormone analog, and in past medicine, it is written as gonadotropic releasing hormone analog. So goserelin is the LHRH analog, the tamoxifen or the raloxifene. They are the selective estrogen receptor modulator, in short SERM. And there is a two drug, bicalutamide and enzalutamide. They are the non-steroidal androgen receptor antagonists or blockers. They are the, in short, they are known as the NSARA. And the cyproterone acetate. Cyproterone acetate is the steroidal androgen receptor antagonist. So bicalutamide or enzalutamide, they are the non-steroidal androgen receptor blocker or androgen receptor antagonist. And abiraterone acetate is a selective androgen synthesis inhibitor that works by blocking the cytochrome P45017 alpha hydroxylase. And the cyproterone acetate, this is the steroidal. So bicalutamide and enzalutamide, these two are the non-steroidal ARB, and cyproterone acetate is the steroidal ARB. And for the metastatic prostate cancer, this is taken from the past medicine. There is anti-androgen therapy, and the example of the goserelin. And also bicalutamide can be used, and also the cyproterone acetate. Now let's get back to the management of bony metastasis in case of metastatic prostate cancer. So for the specific management of the prostate cancer, we can either go with the enzalutamide, bicalutamide, and also with the goserelin. But for the management of bone pain, in case of extensive bony metastasis, this type of patient often presents with the bone pain due to metastasis into the bony region. So the first line treatment should be the IV bisphosphonate, and the alternative is the subcutaneous denosumab. So either you can give the IV bisphosphonate or subcutaneous denosumab, depending on the condition of the patient. And if the patient doesn't respond to this first line treatment, then for next line, you will have to give the external beam radiation therapy. So the IV bisphosphonate or the intravenous cholendronate, this should be the first line treatment. Alternative is the subcutaneous denosumab, and if the patient doesn't respond to it, then we'll have to give the external beam radiation therapy. And transfer to fentanyl patch is only necessary when there is renal impairment here. But the creatinine here is mildly elevated. Potassium is the upper limit of normal range. So there is no need to transfer to the fentanyl patch. IV eventronic and IV cholintronic are both potential options to control pain from the bony metastasis in prostate cancer, and denosumab can be used as an alternative. Second line is the external beam radiation therapy, and fentanyl patch when there will be significant renal impairment. Okay, doctor, next one.
What is the approximate risk of his children suffering symptoms of Fabry's disease? 100%, 50%, 33%, 25%, or 0%. A 48-year-old man is reviewed in the cardiology clinic. He has been diagnosed with cardiomyopathy and also has chronic renal impairment with proteinuria. He is diagnosed with atypical Fabry's disease.
So the father is affected with the Fabry's disease, and the question is about the approximate risk of his children suffering from, meaning how much percentage will be affected. So Fabry's disease follows the X-linked recessive pattern. So if the father is affected, father is carrying one X chromosome and one Y chromosome. So since this is an X-linked recessive condition, so the father's Y chromosome is normal. So all of the sons of this man will be normal, and all of his daughters will be carriers. So 50%. So that means all of his son will be absolutely normal, and all of his daughters will be just the carriers. So the approximate risk of his children suffering from symptoms should be close to zero. So 0% would be the answer. But if the option says 2% or 5% along with 0%, then you should choose either 2% or 5%. In an extreme recessive condition, the Fabry's disease, all the daughters of the affected father are the carriers. For the condition constant, because of the Y chromosome is normal, the sons of an affected father are always normal. So that means the chance of his children suffering from Fabry's disease is approximately zero. So since this is an X-linked recessive condition and the father is affected, so all of his daughters will be carriers and all of his sons will be normal. So ultimately, 0 to 5% individual will be affected.
That is actually
If the mother is carrier.
Turner syndrome.
Yeah, Turner's. Okay, next one, please.
Which of the following is the most likely cause of her skin changes? Erythema chronicum migrans, erythema marginatum, erythema nodosum, pretibial myxedema. Uh, so E is superficial thrombophlebitis. A 23-year-old woman who is 16 weeks pregnant comes to the dermatology clinic for review. She has developed itchy, red, raised nodular lesions on both shins, which have become more prominent over the past 2 weeks. Her pregnancy has been uneventful so far, and she has no health issues apart from the nodular rash. Physical examination is unremarkable. So, what is the most likely cause of her skin changes?
So pregnant lady coming up with the nodular shin lesion and everything other is normal. So the most likely cause of his skin changes here should be the erythema nodosum, because the erythema chronicum migrans, this occurs in case of Lyme disease. There is no features of Lyme disease here. Erythema marginatum, this occurs in case of rheumatic fever. Tibial myxedema occurs in case of Graves' disease, and there is no features of Graves' disease here. And superficial thrombophlebitis. Superficial thrombophlebitis can occur in case of pregnancy, but there will be symptoms of either some sorts of deep vein thrombosis, or there will be calf pain, or there will be pain in the posterior aspect of the leg. And since the patient physical examination is unremarkable, it can also be the superficial thrombophlebitis. So the most likely cause of our skin changes should be due to the erythema nodosum, and erythema nodosum is also very common in case of pregnant lady. So pregnancy with the erythema nodosum, and also we know that the combined or oral contraceptive pill, this is associated with the formation of the erythema nodosum. And erythema nodosum can also occur in case of streptococcal, in case of streptococcal infection, tuberculosis, sarcoidosis, mycoplasma infection, and also with the IBD.
Which of the following is the most appropriate intervention for liver disease? Metformin, pioglitazone, rosuvastatin, vitamin E, and weight loss. A 52-year-old woman comes to the clinic for review. She has abnormal liver function tests noted by her general practitioner and is attending the clinic to discuss management of her condition. She is obese with a body mass index of 35 kg per meter square. Her investigations revealed hemoglobin 11.5, white cell count 6.7, platelets 143, sodium 139, potassium 4.4, creatinine 95, alanine aminotransferase 322. Aspartate aminotransferase 188, alkaline phosphatase 167, bilirubin 15, ultrasound liver showed fatty infiltration.
So abnormal liver function test evidenced by the elevated transaminase along with the fatty infiltration and the elevated BMI or the obesity. So abnormal transaminase plus obesity plus fatty infiltration. So the most likely diagnosis here is the NAFLD or the NASH, non-alcoholic fatty liver disease or non-alcoholic steatohepatitis. And if there is abnormal liver function test plus the ALT into AST ratio greater than 2, the BMI of the patient is normal and the patient has a history of taking alcohol, that would be the diagnosis of the alcoholic liver disease. So in case of alcoholic liver disease, the patient BMI would be normal, there will be no fatty infiltration, and the patient will have a long history of taking alcohol and will have the classical ALT to AST ratio greater than 2. But in case of non-alcoholic fatty liver disease, the patient will be obese and you don't follow the criteria of ALT to AST greater than 2. The patient will show the fatty infiltration in case of ultrasound of the liver. And the first line treatment for the NAFLD or the NASH is the weight loss. And there is also another special criteria according to the NICE guideline. If a patient comes up with the features of non-alcoholic fatty liver disease and her BMI is greater than or equal to 35, then we'll have to give the liraglutide. Liraglutide should be given if the patient has the non-alcoholic fatty liver disease plus the BMI greater or equal to 35. Can anyone tell me the mode of action of liraglutide?
So incretin.
Exhilarating, I think so.
Incretin, what's that?
Lipase inhibitor, GLP-1 mimetics.
Yes, it's the
Minus,
GLP-1 mimetic.
yeah.
So features of rash plus obesity, meaning the BMI greater or equal to 35 kg per meter square, the choice of treatment should be the liraglutide. This is according to the current NICE guideline. And the exenatide or the liraglutide, they are the GLP-1 analog or agonist. And A for acarbose and A for alpha alpha. So acarbose is the alpha glucosidase inhibitor. And pioglitazone has G and here is the gamma. So G for gamma, meaning pioglitazone is the PPAR gamma receptor agonist, and the gliptins are the DPP4 inhibitor, and the gliflozins are the SGLT2 inhibitor. Can anyone tell the full form of PPAR?
Peroxisomal proliferator.
Go on.
Can I see the peroxisomal proliferator activated receptor?
Yes, this is the paroxysm proliferator activated receptor. This is the full form of PPAR.
Yeah,
Just
which
look at,
happened because
yeah, and
increased
just look at here.
proliferation.
PPAR has one alpha agonist and another one is the PPAR gamma agonist. So G for gamma, G for glitazone. So the thiazolidinedions or the pioglitazone, rosiglitazone, all of them are the PPAR gamma agonist. and the fibrate is the PPAR alpha agonist. So don't get confused between the two. So the glitazones are the gamma agonist, the fibrates are the alpha agonist. So morbidly obese with the features of NASH, possibly the treatment should be the weight loss followed by the liraglutide. So here is the paroxysm proliferator activated receptor gamma agonist. Okay, next one.
Which of the following is the most likely cause of her hearing loss? Acoustic neuroma, polystatoma, loss of inner ear hair cells, otosclerosis, tympanosclerosis. A 76-year-old woman comes to the clinic for review. She complains that over the past few years, she has found it increasingly difficult to hear people talking, conversations in crowded places, and that speech seems muffled or slurred. She has hypertension and has had a previous inferior myocardial infarction, but is otherwise well. Her blood pressure is 139/82 millimeters of mercury, and her pulse is 70 beats per minute and regular. Her body mass index is 23 kilogram per meter square. Which of the following is the most likely cause of her hearing loss?
So this patient is having the isolated hearing loss and the patient is in the geriatric age group and there is no other symptoms here. So most likely this is a case of senile hearing loss. So what's the underlying pathology in case of senile hearing loss?
C.
See.
Loss of inner ear hairs.
Loss of inner ear hairs. Can anyone tell me the presentation of the acoustic neuroma? How does acoustic neuroma presents like? Okay, just
It is
imagine
associated with neurofibromatosis.
this may be associated with the neurofibromatosis, but I'm asking about the clinical presentation of the acoustic neuroma.
decrease in hearing and the balance.
It's unilateral.
Okay,
The balance, I think, the balance, loss of balance.
so
Associated with tinnitus as well.
so
Seek
acoustic,
and
acoustic
see
neuroma.
teacher.
Okay,
Progressive
yeah.
type of sensory neural loss, but along with the unilateral, there will be unilateral loss, not the bilateral.
Acoustic neuroma is mostly associated with the unilateral hearing loss, and I'm just giving you a scenario. A person was watching the television means TV, and the patient developed the unilateral hearing loss. So TV means T for tinnitus, V for vertigo. So the patient will have tinnitus, vertigo plus the unilateral hearing loss. So this triad will be present in case of acoustic neuroma. So T for tinnitus, V for vertigo, and the patient will have the unilateral hearing loss. And
Is it completely, sorry, is it completely hearing loss or decrease hearing?
this is the gradual hearing loss. This is not the complete hearing
Yeah,
loss. The patient will have the gradual hearing loss. Okay,
yeah.
and can anyone tell me the presentation of autosclerosis? Autosclerosis is an autosomal dominant condition. So in this case, the primary is previously present, and the patient will come up with the features of progressive hearing loss, and this occurs due to calcification of the stapes footplate. The footplate will get fused with the other portion of the bony particles, and the patient will also come up with the hearing loss. And sclerosis means the calcification. Tympano means the tympanic membrane. So this indicates the calcification of the tympanic membrane. This occurs when the patient have a chronic history of suppurative otitis media. So loss of inner hair cell function is the primary cause of senile hearing loss. The progressive loss of hair cell function leads to the gradual hearing loss over a number of years, and difficulty with hearing speech, particularly in the crowded location. And the acoustic neuroma is the T for tinnitus, and vertigo. Vertigo often comes up with the dizziness, and the patient will have the unilateral hearing loss. And the choice of investigation should be, yes?
There is corneal reflex loss in the acoustic neuroma. Is it right? Yeah.
Yes,
Okay.
yes, exactly. The loss of the absent corneal reflex ACR. ACR, I remember like this, ACR is equal to AN. So absent corneal reflex is equal to the acoustic neuroma. So there will be loss of the corneal reflex, or it will be absent in case of acoustic neuroma. And autosclerosis is the ankylosis, or the calcification of the stapes footplate, and this footplate will be fused with the other bony portion of the ear, and this should be corrected surgically, meaning with the stapedectomy. And tympanosclerosis is the calcification of the tympanic membrane, and tympanic membrane is only calcified when there is chronic period of the suppurative otitis media. Okay, next one.
Which of the following is the most appropriate intervention? Citalopram, counseling, individual cognitive behavioral therapy, risperidone, vermicline. A 23-year-old woman presents to the clinic for review. She tells you that she is constantly worried about her appearance and the shape of her body, and has now undergone a range of cosmetic procedures, including breast surgery, lip filler, injection, and
Go on. Carry on. We can't hear you.
hello.
I think
Yes,
we lost.
I
Yeah,
lost
continue, please.
actually
Okay.
connection. So she is now worried about the shape of her nose and says that it's making her feel so depressed that she wakes at 5 a.m. Every morning thinking about it, and is unable to go out for fear of people's opinion about her. Physical examination is entirely normal. Which of the following is the most appropriate intervention?
So this is a classical case of the body dysmorphic disorder, and in the first session I said the treatment for all psychiatric condition except schizophrenia, the first one treatment is always the CBT. So this is a case of body dysmorphic disorder. So the first line treatment will also be the CBT, and the second line treatment should be the SSRI, selective serotonin reuptake inhibitor. So CBT should be the first line, citalopram should be the second line. What is the indication of varenicline? Indication of varenicline?
It's for
Nicotine replacement therapy.
Smoking withdrawal symptoms. Yeah.
Yeah, exactly. This is used in the treatment for smoking cessation. And what is the mode of action of varenicline?
It's the nicotinic receptor
Nicotine
agonist.
receptor agonist. Yeah.
Yes, exactly. Okay, just look at here. Both varenicline and the bupropion, both of them are used in the management of smoking cessation. But one of them is the agonist, another one is the antagonist. So varenicline is the nicotinic receptor partial agonist. This is not the full agonist. This is the partial agonist. And bupropion has a dual mode of action, and this is the nicotinic antagonist, or you can just remember this is the nicotinic blockers. So B for bupropion, B for the nicotinic blockers, and varenicline is the agonist. And this is also the norepinephrine and dopamine reuptake inhibitor. And bupropion should not be used in a patient with epilepsy as it reduces the seizure threshold. So if a patient has the history of epilepsy or seizure, then bupropion is contraindicated. So individual CBT is the intervention of choice for patient with the body dysmorphic disorder. And varenicline is the partial nicotinic receptor agonist. And one of the notorious side effects of the varenicline is the nausea and vomiting. Okay, next one.
Which of the following is the most likely location of any lesion causing the visual field loss? Bilateral occipital lobe infarcts, craniopharyngioma, left parietal lobe infarct, right temporal lobe infarct, and E option,
pituitary adenoma.
adenoma. So a 47-year-old man comes to the ophthalmology clinic for review. He has noticed visual field loss being more marked on the left than on the right, where he loses sight of objects at his feet. Mapping of his visual fields at the optometrist has demonstrated near complete loss of the lower half of the visual field on the left hand side and loss of 2/3 of the lower half of the visual field on the right hand side. Which of the following is the most likely location of any lesion causing the visual field loss?
So this is the question regarding the visual field loss. So we need to discuss in details. So this is a long list of the visual field defect. If there is infraction or some sort of occlusion in the occipital lobe, occluding the posterior cerebral artery or the PCA stroke, then the patient will have the contralateral homonymous hemianopia. In case of optic chiasma lesion, there will be bitemporal hemianopia. And in case of temporal lobe, there will be contralateral superior homonymous quadrandoanopia. And in case of parietal lobe, contralateral inferior homonymous quadranopia. And you can remember these two with the mnemonic PITS, PITS. So parietal for inferior, temporal for the superior. And bitemporal inferior quadranopia, this is if there is any kinds of lesion in the Rathke's pouch, meaning if there is craniopharyngioma, then the problem will be in the bitemporal in the inferior quadranopia. And in case of pituitary tumor, it will be superior. So craniopharyngioma comes up with the bitemporal inferior quadranopia, and pituitary will come up with the bitemporal superior quadranopia. An optic nerve will have the central scotoma, occipital cortex with the cortical blindness. So C for occipital has C, C for cortex, this will come up with the cortical blindness. And third nerve palsy with bitemporal hemianopia, this is associated with the internal carotid artery aneurysm. There is a syndrome called the Weber syndrome. This occurs due to the posterior cerebral artery or the occipital lobe infarction. This is also known as the midbrain infarction, and the patient will have the ipsilateral third nerve palsy with contralateral hemiplegia. So in case of internal carotid artery aneurysm, there was bitemporal hemianopia plus third nerve palsy. And in case of Weber syndrome or midbrain infarction, there will be ipsilateral third nerve palsy with contralateral hemiplegia. So bitemporal inferior quadranopia, the problem is it is due to the craniopharyngium. So if we look at
Is
here,
it inferior quadrantropia or it is inferior hemianopsia?
hemianopia and quadranopia are almost same, are the identical words, no problem with them. So just look at here.
Quadranticopia, isn't it 1/4, 1/4 or something like? And
Yeah, quadrantropia is just the one quadrant affected from the four quadrants. In hemianopsia, the two quadrants are affected.
yeah, in optic radiation that can happen. And
So if we look at here, the left side is affected as well as the right hand side. So this is the bitemporal and problem is in the inferior lower half. So this is bitemporal inferior quadranopia. So the most likely cause of lesion should be due to the craniopharyngium, and if it was due to superior, in the superior portion, then the lesion would be in the pituitary adenoma. Craniopharyngioma leads predominantly to superior pressure on the optic chiasma. This leads to progressive inferior visual field loss with an inferior hemianopsia as seen here. Tumor growth may be more marked on one side than on the other, accounting for the greater visual field loss on the left than the right. In this case, magnetic MRI is the investigation of choice. Okay, next one.
A 61-year-old woman who has persistent diarrhea presents to the gastroenterology department for review of her colonoscopy results. She takes a number of medications for diabetes, cardiovascular disease, and gastroesophageal reflux disease. Her biopsies reveal microscopic colitis. Which of the following is the most likely cause of her colitis? Amlodipine, bisoprolol, dapagliflozin, lansoprazole, sitagliptin.
So this is the question from the pharmacology: drugs causing the microscopic colitis, and the patient with microscopic colitis will come up with the watery diarrhea. So what are the drugs that causes the microscopic colitis?
Lansoprazole.
Lansoprazole.
Just and sets.
The PPI and NSAIDs, and most probably also the SSRI, all of them causes the microscopic colitis. So both PPI and the NSAIDs, both of them causes the microscopic colitis. So here PPI is the lansoprazole. So proton pump inhibitor is a recognized cause of the microscopic colitis, and this type of patient comes up with the features of watery diarrhea. The patient will have chronic watery diarrhea and also acarbose, and most probably in past medicine or somewhere there may be SSRI also.
Yeah, I heard it in one lecture of Dr. Salman. There was one case he mentioned it. SSR is one of the causes of microscopic colitis.
Yeah, most probably, because I have read somewhere else it was a cause of microscopic colitis. So let's try to find out. And there are some other drugs causing the microscopic colitis. So PPI, only PPI is mentioned. Okay.
What do you mean by microscopic colitis?
The microscopic colitis means there will be some sort of inflammation in the colon, but that won't be visible. That won't be visible in case of colonoscopy. That can only be recognized by going through the some sort of biopsy or some other tissue diagnosis, not with the colonoscopy directly. So this is known as the microscopic. You'll have to recognize that with the help of microscope. Okay, next one.
A 24-year-old traveler comes to the emergency department some 4 weeks after returning from an extended trip to Thailand. During his trip, he had unprotected sexual intercourse with a number of casual partners. He says that during his trip, he did develop a painless ulcer on his glans penis, which took some time to heal. Examination reveals a number of macular erythematous lesions measuring up to 2 centimeters across, affecting predominantly the palm of his hands and sole of his feet, although some lesions are also appearing on his body. Which of the following is the most likely cause of his skin rash? Donovanosis, generalized gonococcal infection, generalized herpes simplex, lymphogranuloma venereum, secondary syphilis.
So history of sexual exposure, coming up with the painless ulcer and also the rash. So what should be the most likely diagnosis here? Coming up with the rash.
Secondary syphilis.
Very good. Among the option given here, only secondary syphilis is associated with the rash. So let's look at the sexually transmitted disease coming up with the ulcers. So in case of syphilis, the patient will come up with the single painless ulcer, and the patient will have the delayed painless lymph node involvement. So both ulcer is painless, lymph node is painless. So this occurs in case of syphilis. In case of lymphogranuloma venereum, there will be single painless ulcer, but the lymph node will be painful. So here we are getting both are painless, minus minus, and in case of lymphogranuloma venereum there is minus and here is plus. So single painless ulcer plus early painful lymph node involvement. This is the diagnosis is the lymphogranuloma venereum. And in case of granuloma inguinally, usually there will be no lymph node involvement, but there may be some sort of lymph node involvement in case of advanced or chronic cases, but in most of the cases, there will be no lymph node involvement. And there will be painless, and this is ulcers, meaning there will be multiple ulcers. So if a patient comes with the painless ulcer, at first we'll have to see whether this is single ulcer or multiple ulcers. If this is multiple ulcer, no lymph node involvement, then the diagnosis is the granuloma inguinale. And if the single painless ulcer is associated with the painful lymph node, this is lymphogranuloma of Vanderham. And single painless ulcer with painless lymph node involvement, the diagnosis is the syphilis. And in case of secondary syphilis, we will get the features of skin rash. And both chancroid and herpes simplex infection, both of them will come up with the painful ulcer. So painful ulcer has two differential diagnoses. One is the chancroid and another one is the herpes simplex. And herpes simplex is always multiple painful ulcer. This will always be multiple painful ulcer. Chancroid may be single painful ulcer, and in some cases it may be multiple. But herpes simplex is always will always come up with the multiple painful ulcer, and both of them will come up with the painful lymph node involvement. And if we look at the organism, the genital herpes occurs due to herpes simplex virus. Syphilis organism is the Treponema pallidum. Chancroid is the Haemophilus stupri, and lymphogranuloma venereum is the Chlamydia trachomatis.
So which of the following is most likely cause of...
Doctor, isn't it the primary syphilis which has painless ulcer in syphilis?
Syphilis is painless ulcer. Was there any pain present?
No, there is no pain, but in primary syphilis there is a painless ulcer. Does it progress to a painful ulcer later on in secondary? Because
Secondary.
I remember painless ulcer is present in primary syphilis.
It is same in the secondary as well. They are
Is it
saying only syphilis, okay? Yeah, not painful. It is always painless, okay?
Uh-huh.
So, yeah.
Okay.
What were you saying?
Okay. Next.
Which of the following is the most likely cause of her incontinence? Functional incontinence, overactive bladder syndrome, overflow incontinence, stress incontinence, and urge incontinence. A 78-year-old woman comes to the clinic for review. She has obesity, type 2 diabetes, and osteoarthritis, and complains of urinary incontinence over the past year. He says this is made worse with sneezing, coughing, or when she strains to get up out of a chair. Examination reveals a body mass index of 33 kg per meter square, and pelvic examination reveals a urethral prolapse. Urine testing at the general practice has revealed intermittent blood and proteinuria and positivity to nitrites, which has been treated each time with nitrofurantoin. Which of the following is the most likely cause?
So elderly woman with having the features of obesity and also history of urethral prolapse, and worse with sneezing, coughing, and when she strains to get up with the chair. So urethral prolapse or genitourinary prolapse plus the worsening of the incontinence with sneezing, coughing. So the most likely diagnosis is the stress incontinence, and the urethral or genitourinary prolapse. This is one of the most important risk factor for the development of the stress incontinence. And the first line treatment of stress incontinence should be which one? It should be
Pelvic floor exercise.
no. The first line treatment for stress incontinence is the pelvic floor exercise, followed by the Dulot setting. And overactive bladder occurs due to overactivity of the detrusor muscle. So detrusor muscle overactivity, which is give rise to the overactive bladder syndrome, and this can be treated by giving the anticholinergic drugs. And the urge incontinence,
bladder retraining?
Which one? Stress
Overactive.
stress
Overactive.
incontinence.
No. Overactive bladder.
Overactive bladder. The first line treatment for the overactive bladder is the bladder retraining, followed by the anticholinergic drugs. And in case of urge incontinence, the patient will have the history of the involuntary leakage of the urine. And this usually occurs in the neurological condition like either a stroke patient or Parkinson's disease patient, in the elderly patient with some research of neurological disease. And this can be treated with the anticholinergic drug. And if the patient is elderly or the patient has some sort of confusion or dementia, then in that case we'll treat the patient by giving the mirabegron. And solifenacin can also be given in the elderly patient. So stress incontinence with involuntary leakage of urine on effort or exertion or on sneezing and coughing, and exacerbated by the genitourinary prolapse. So the diagnosis is the stress incontinence. First line treatment is the pelvic floor exercise followed by the duloxetine. And the overflow incontinence, this usually occurs in the patient with benign prostatic hyperplasia. Okay, next one.
Which of the following is the most likely location of the lesion causing this patient's aphasia? Arcuate fasciculus, left precentral areas, left temporal lobe, left perisylvian region and thalamus, supplementary motor area. A 64-year-old man is reviewed on the stroke ward a few days after suffering a large middle cerebral artery stroke. He is noted to have global aphasia. Most likely location of the lesion.
So patient is having the MC stroke and the global aphasia. So when the global aphasia occurs in case of MC stroke, what is the lesion in case of global aphasia?
Cerebral artery, both branch, superior and inferior, supplying both the vernicis and the Broca's area.
So if a patient with the MC stroke comes up with the global aphasia, then the most likely site of lesion means there should be extensive damage to the left perisylvian region, thalamus, white matter, and the basal ganglia. There should be extensive damage to all of these four location, and in the option left perisylvian region was mentioned. So left perisylvian region and the thalamus, this should be the answer here. Global aphasia occurs when extensive damage occurs to the left perisylvian region, white matter, basal ganglia, and thalamus, all the four. And deficit is usually seen in comprehension, repetition, naming, and speech production.
Which of the following is the most likely cause of her confusion? Bipolar disorder, drug-induced psychosis, encephalitis, schizophrenia, and thyrotoxicosis. A 43-year-old woman is brought to the emergency department by ambulance with one of her work colleagues. She has been taken unwell at a company sales conference where she told the team that she can speak 10 languages and would lead the team to victory, having a 100% understanding of the problems ahead. When she arrives at the hospital, she tells you that she is related to the royal family and that she is a very important person. She has clear pressure of speech and tells you that she can predict the chances of recovery of other patients in the department. She refuses physical examination. Most likely cause of her confusion.
So this patient is having the pressure of speech, and she thinks that she is related to the royal family. So related to the royal family, this indicates the overinflated opinion or overinflated syndrome, and this is an example of the delusion of grandeur. So the most likely diagnosis here is the bipolar disorder or the mania. And we know that bipolar disorder has two components. One is mania, another one is the hypomania. So how will we differentiate between the mania and the hypomania? The presence of psychotic symptoms differentiates mania from the hypomania. And in case of mania, the psychotic symptoms will be present. In case of hypomania, the psychotic symptoms will be absent. And how will we recognize the psychotic symptoms? Psychotic symptoms can be recognized by AD. AD doesn't mean autosomal dominant. AD here means A for auditory hallucination, D for delusion of grandeur. If this feature, either one is present, then the diagnosis is the mania. So here the delusion of grandeur is present. So this is a case. This patient has the manic episode. So I am repeating again, the presence of psychotic symptoms differentiates mania from the hypomania. Mania will have the psychotic symptoms. Hypomania won't have the psychotic symptoms, and psychotic symptoms are the A and D. A means auditory hallucination and D means delusion of grandeur. So if either auditory hallucination or delusion of grandeur is present, then the diagnosis is the mania. And if both of the components are absent, then the diagnosis is the hypomania. So this is the first episode of the mania, and the patient has the component of delusion of grandeur. And bipolar disorder and the manic phase, they should be treated by giving the atypical antipsychotic. The first line drug is the risperidone, and second line drug is the olanzapine, and olanzapine is associated with the weight gain.
Which of the following additional interventions is the most appropriate? Furosemide, octreotide, orbital radiation, rituximab, and tocilizumab. A 41-year-old woman who has Graves' disease treated with a block and replace regimen comes to the emergency department with worsening vision. On examination, she has marked proptosis with lid lag and conjunctival injection, consistent with Graves' ophthalmopathy. She complains of blurred vision and loss of color vision, particularly over the last 24 hours, and her visual acuity has deteriorated markedly since her clinic visit 1 month earlier. She is prescribed high-dose corticosteroids. Additional interventions, most appropriate additional interventions.
So the patient had the Graves' disease and also the Graves' ophthalmopathy, and the patient was treated with the block and replace regimen as well as the high dose corticosteroid. But still, the patient presented with the worsening of the vision despite giving the block and replace regimen and the high dose steroid. So this is a case of uncompensated thyroid eye disease. So what should be the next line of most appropriate treatment in case of uncompensated or decompensated? Sorry, no, it's not the uncompensated, it's the decompensated thyroid eye disease management.
Antibody. Totally D4 thyroid D4 tocilizumab.
So if a patient has the Graves' ophthalmopathy, depending on the situation, we'll have to either give the prednisolone or the IV methylprednisolone. If the patient has some features of visual impairment or some sort of visual acuity problem, then we'll have to start with the IV methylprednisolone. But if the case is a mild case, we can go with the oral prednisolone. And if still the patient is symptomatic and there's worsening of the visual problem, this indicates this is the case of decompensated thyroid eye disease, and the next choice of treatment should be either tocilizumab or rituximab or cyclosporine. We'll have to give either of the one, and we'll have to remember the serial. First is tocilizumab, after that is rituximab, then is cyclosporine. So T or C. tocilizumab, rituximab, and the cyclosporine. So already steroid has been given, so the next choice of treatment should be the tocilizumab, and after tocilizumab we can go with the rituximab, and after rituximab we can go with the cyclosporine. And the radioiodine, the radioiodine therapy, this causes worsening of the grapes ophthalmopathy. So if a patient has the thyroid eye disease, we can give the radioiodine therapy.
So a 23-year-old woman of Han Chinese ethnic origin comes to the clinic for review. She has recently been diagnosed with complex partial epilepsy. She has no other past medical history. Which of the following is the most appropriate anti-epileptic medication for her? Clonazepam, levetiracetam, oxcarbazepine, sodium valproate, topiramate.
So the default choice of treatment in case of complete partial seizure is the sodium valproate. But since the patient is of the reproductive age group, and sodium valproate has the teratogenic effect, so we can give sodium valproate in this patient. If the patient was 23-year-old man, then the treatment can be given as the sodium valproate. But since he is a woman of reproductive age group, sodium valproate should be avoided, and we should go with the levetiracetam. And the second line, if the patient doesn't respond to levetiracetam, then topiramate can be added along with the levetiracetam. And oxcarbazepine or the carbamazepine can also be used, but oxcarbazepine or carbamazepine, this is associated with the Stevens-Johnson syndrome and often not preferred compared to the levetiracetam. And clonazepam is not the treatment of choice in case of complex partial epilepsy. Which of the following best describes the mode of action of letrozole?
A. Aromatase inhibitor.
Aromatase inhibitor.
Yes, very good. This is the aromatase inhibitor. Which one is 5-alpha reductase inhibitor?
Finasteride.
Yes, finasteride. And finasteride is used in the treatment of benign prostatic hyperplasia. 21 hydroxylase inhibitor. This is associated with which disease?
Congenital hyperplasia.
EDH maybe.
The 21 hydroxylase inhibitor, this is associated with congenital adrenal hyperplasia. And does this patient present with hypertension or normotension? Hypotension or normotension? In case of 21.
Normal tension.
Normal, yes.
Why normotension? Because there will be salt wasting. Okay.
There is adrenal deficiency.
Yes, exactly. There will be adrenal deficiency and there will be salt wasting in case of 21 hydroxylase deficiency. So the patient won't present with the features of hypertension. Okay, look at here. 21 hydroxylase deficiency. This is associated with the congenital adrenal hyperplasia. And the clinical presentation would be irregular menses, acne, hirsutism, early breast and pubic hair development, clitoromegaly, and the male pattern baldness. So the 11 beta hydroxylase deficiency, these will be associated with the hypertension because in case of 11 beta hydroxylase deficiency, there will be there will be no features of salt wasting. But the 21 hydroxylase deficiency, this is associated with the salt wasting, so the patient won't present with the hypertension. And there are other condition patient coming up with the hypokalemia plus hypertension. One is the Cushing syndrome, Cone syndrome, Liddle syndrome, and 11 beta hydroxylase deficiency. So all of them will have the hypokalemia as well as the features of hypertension. But 21 hydroxylase deficiency is on present with the features of hypertension. Okay. letrozole. So letrozole is the aromatase inhibitor, and this is the non-steroidal. This is not steroidal. This is the non-steroidal aromatase inhibitor.
A 20-year-old student presents to the emergency department with 10 kilogram weight loss over the past month, as well as polyuria, polydipsia, and balanitis. He has no significant medical illnesses. His blood pressure is 105 by 80, with a postural drop of 15 millimeters of mercury on standing. His body mass index is 19 kilogram per meter square. Investigations: hemoglobin 15.9, white cell count is 9.8, platelets 301, sodium 144, potassium 4.8, creatinine 142, glucose 28 millimoles per liter. Which of the following antibodies is most likely to be positive? Anti-glutamic acid decarboxylase 65, GAD 65, anti-nuclear, anti-smooth muscle, anti-tissue transglutaminase TTG, anti-zinc transporter protein 8.
So this patient is having the classical features of diabetes: polyuria, polydipsia, polyphagia, and also there is some sort of complication there. Balanitis has occurs with the postural drop, weight loss, and there is low BMI. So most likely the patient has either insulinoma or the type 1 diabetes, and glucose is also elevated here. So we'll have to look for the anti-GAD antibody, because anti-GAD antibody is usually present in case of type 1 diabetes or the autoimmune diabetes mellitus. So we'll have to go with anti-GAD. And anti-ANA can be raised in long list of causes. Anti-smooth muscle in case of autoimmune hepatitis. TTG is associated with the celiac disease, and celiac disease is associated with the dermatitis herpetiformis. And anti-zinc transporter protein, this may be present in also in case of type 1 diabetes, but this is less likely in small percentage. Most of the patient with type 1 diabetes has the anti-GAD positivity. So anti-GAD antibodies are a useful marker of autoimmune beta cell attack, particularly in adults presenting with the diabetes mellitus. The symptoms here are of insulipemia, making the type 1 diabetes most likely, although the exact percentage differs across case series. Around 60% or more of the adults presenting with the type 1 diabetes for the first time are the anti-GAD positive. So anti-GAD would be positive in case of type 1 diabetes, and it would be negative in case of MODY, maturity onset diabetes of the young.
Which of the following is the most likely cause of his symptoms? Alcoholic liver disease, polycystitis, non-alcoholic fatty liver disease, primary sclerosing cholangitis, or viral hepatitis. A 67-year-old man is admitted to the emergency department with nausea, vomiting, and right upper quadrant pain. This is his third attendance at the hospital with similar symptoms over the past 6 months. He has type 2 diabetes, for which he takes metformin, and hypertension, which is treated with ramipril. His blood pressure is 155 by 90 millimeters of mercury, and his pulse is 92 beats per minute and regular. His temperature is 38.2 degrees centigrade. Abdominal examination reveals tenderness in the right upper quadrant. His body mass index is 33 kilogram per meter square. Investigations: hemoglobin 14.5, white cell count 15.2, platelets 323, sodium 142, potassium 4.6, creatinine 95, alanine aminotransferase 89. Okay, aspartate aminotransferase 78, alkaline phosphatase 254, bilirubin 28. Which of the following is the most likely cause of his symptoms?
So this patient is having the right upper quadrant pain and tenderness. Patient is obese with features of leukocytosis, and if we look at the hepatic blood picture here, there is mild elevation of ALT and AST, and there is significant elevation of the alkaline phosphatase and also bilirubin, indicating this is the obstructive pattern. So obstructive pattern of hepatic picture plus plus leukocytosis, obesity, and right upper quadrant pain. So what should be the most likely diagnosis here? Yes, exactly. It should be cholecystitis. So why not alcoholic liver disease? Because in case of alcoholic liver disease, this will have the classical pattern of ALT to AST ratio greater than 2, and the alkaline phosphatase and bilirubin, they will be either normal or mildly elevated, and the patient's PMI would be in the normal range, and the patient won't have the right upper quadrant pain, and patient will have the long history of taking alcohol. Non-alcoholic fatty liver disease, this occurs this occurs in a patient with elevated transaminase plus obesity, and there will be no obstructive pattern here, and the ultrasound will show the fatty infiltration, and usually the non-alcoholic fatty liver disease does not come with the right upper quadrant pain or abdominal pain. PSC is associated with the ulcerative colitis. PSC is equal to UC. So PSC will have the history of the ulcerative colitis, and for ulcerative colitis, the patient will have the history of the bloody diarrhea, but the features are absent here, so it can be the PSC. And in case of viral hepatitis, there will be significant elevation of the transaminase. The condition causing the elevation of transaminase greater than 1000, what are the condition? Differential diagnosis, transaminase, ALT and AST greater than 1000. What are the condition? There are three, most probably 3 or 4 conditions. Anyone? So the transaminase, meaning the AST and the ALT, the AST and the ALT level should be greater than 1000, and the differential diagnosis of the ischemic hepatitis, acute viral hepatitis, and paracetamol toxicity or overdose. So in this 3 condition, the AST and the ALT level, either both of them or at least one of them should be greater than 1000. And the differential diagnosis of the ischemic hepatitis, acute viral hepatitis, and paracetamol toxicity. So in case of viral hepatitis, the transaminase ALT and AST ratio should be greater than 1000, and the ALP and bilirubin level will remain almost normal.
Which of the following is the most likely organism identified? Corynebacterium, Enterococcus, Moraxella, Pasturella, Propionibacterium. A 54-year-old man comes to the acute medicine clinic for review of a dog bite on his left hand. He didn't attend the emergency department initially, and a wound swab has now demonstrated gram-negative bacilli. Most likely organism identified.
Pasturella.
Yes, very good. Dog bite. The commonest organism in case of dog bite is the Pasturella multocida, and the commonest organism in case of human bite is the Streptococcus ancynosus, and the cat scratch disease will have the Bartonella henseli. And what should be the first line treatment for dog bite?
Amoxicillin.
Yes, very good. It should be the co-amoxicillin. Go on, next question.
Which of the following is the most appropriate next step? Aspirin 600 milligram, colonoscopy in 3 years, colonoscopy in 10 years, reassurance, yearly colonoscopy. A 32-year-old man is reviewed in the cancer genetics clinic following a diagnosis of Lynch syndrome, hereditary non-polyposis colorectal cancer. His brother died from colorectal cancer aged 39, and his father passed away from colon cancer at the age of 48. The patient has had two right-sided colonic adenomas, 1.2 centimeter and 1.4 centimeter, resected at colonoscopy. Most appropriate next step.
Aspirin.
So this patient is having the Lynch syndrome, and this Lynch syndrome is also known as the ASNPCC. And they are asking how to reach the radius of the further risk of the colorectal cancer, and two drugs can be used for reduction of the colorectal cancer. One of them is the aspirin. What's the other one?
Vitamin D.
Yes, very good. Other one is the vitamin D. So the vitamin D will decrease the colon cancer risk, and also the aspirin. Can anyone tell me the mode of action of vitamin D? Mode of action of vitamin D.
Reduces cell proliferation.
Vitamin D will cause the decreased T helper 1 cell response. And vitamin D will also causes the increased calcium and phosphate reabsorption from the gut. So increased calcium and phosphate reabsorption from the gut. This is one of the mode of action of vitamin D. Another one is the decreased T helper 1 T cell response. So this is decreasing the response of the T helper 1 T cell. So aspirin and the aspirin should be of high dose. Aspirin 600 milligrams. So both aspirin and the vitamin D can be given in order to reduce the risk of further colorectal cancer.
A 71-year-old man is reviewed in the clinic after his third admission in the past year with right lower lobe pneumonia, thought to be related to aspiration. He also complains of a chronic cough, difficulty swallowing, and persistent halitosis. He has lost 2 kilograms in weight over the past year. He smokes 5 cigarettes per day and uses a salbutamol inhaler. Physical examination is unremarkable. Investigations: hemoglobin 12.9, white cell count 8.2, platelets 299, sodium 142, potassium 4.3, creatinine 99. Which of the following is the most likely cause of his recurrent pneumonia?
Pharyngeal pouch.
Gastroesophageal reflux, gastric cancer, esophageal cancer, or pharyngeal pouch.
Pharyngeal pouch. Halitosis persistent halitosis is a significant symptom for the pharyngeal pouch.
Yes, exactly. Dysphagia plus persistent halitosis, the diagnosis is the pharyngeal pouch, unless otherwise proved, because the persistent halitosis or palitosis, this is pathognomonic for the pharyngeal pouch. So P for pharyngeal pouch, P for pathognomonic, P for palitosis, or the persistent halitosis. So dysphagia plus halitosis plus minus features of pneumonia or aspiration pneumonia. The diagnosis is the pharyngeal pouch, and this type of patient should be treated surgically. The picture here of the chronic dysphagia with halitosis and recurrent aspiration pneumonia is the typical scene in case of the pharyngeal pouch. It is floating food within the pouch which leads to the halitosis, and regurgitation of the food materials from the pouch which leads to aspiration pneumonia. Barium swallow is the initial investigation of choice because of the risk of perforated carried with the endoscopy. Cricopharyngeal myotomy using the minimally invasive technique to stable the pouch is the initial intervention of the choice because because the food particle will be stored in between the cricopharyngeal and thyropharyngeal, in between cricopharyngeal and thyropharyngeal muscular wall. Diverticulectomy can be considered if the pouch is particularly large. So the minimal invasive technique is the cricopharyngeal myotomy, and for extensive cases, we will go with the diverticulectomy. And why not esophageal cancer? Because all the features of neoplasm are absent here, because there the patient doesn't have the weight loss here. And in case of esophageal cancer, okay, let me tell you another thing. This is the gastro. Dysphagia affecting both solid and liquid food particles from the start. We should think about the achalasia cardia. So in case of achalasia cardia, the dysphagia will from the initial stage affect both liquid food particles and also the solid food particles, and the percentage of effects will be equal. But in case of neurological condition, the dysphagia will first affect the liquid type of food particles only. And in case of cancer, the dysphagia will at first affect the solid food particles. So both solid and liquid food particles from the beginning. Think of achalasia cardia. Solid greater than liquid, or solid initially followed by liquid. This occurs in case of neoplastic condition. Liquid greater than solid, or starting with liquid followed by solid. This occurs in the neurological condition like the myasthenia gravis.
A 27-year-old woman who runs a vegetarian food stall comes to the emergency department with nausea, vomiting, and abdominal pain. She has also developed areas of purpuric skin rash and petechiae and complains of increasing headaches over the past 24 hours. According to her boyfriend, she also appears increasingly confused. Her blood pressure is 155 by 90 millimeters of mercury and pulse 95 beats per minute and regular. Her abdomen is soft with active bowel sounds, although it is generally tender. Her mini, her mini mental state examination MMSE score is 13 by 15. Investigations: hemoglobin 8.7 grams, fragmented red cells seen on blood film, white cell count 14.9, platelets 25, sodium 144, potassium 5.9, creatinine 197, bicarbonate 17. Which of the following is the most likely cause of her presentation? Botulism, Escherichia coli infection, Mycoplasma infection, Salmonella, Shigella infection.
E. coli infection. It is hemolytic syndrome.
Is it hemolytic uremic syndrome, or is it thrombotic thrombocytopenic purpura?
PTP, because it's confused. PTP,
Yes,
yes.
exactly. The patient has TTP. Can anyone tell me the pentad of TTP? Classical pentad of TTP? Anyone? What will be the 5 classical features of thrombotic thrombocytopenic purpura?
So the neurological symptoms plus along with features of HUS.
So the neurological sign or the confusion, this will point towards the TTP, and this neurological sign will be absent in case of hemolytic uremic syndrome. And in case of hemolytic uremic syndrome, there will be significant elevation of urea level and significant impairment of creatinine level. But in case of TTP, there will be mild to moderate renal impairment, and there will be mild increase in urea level. But the neurological features will always be present in TTP, which will be absent in case of hemolytic uremic syndrome. And TTP occurs due to ADAM-TS13 inhibition or deficiency due to failure to cleave the von Willebrand factor. And look at the pentad, the classical features of the TTP, and the neuroscience. The neuroscience is the most important here because it will differentiate from the hemolytic uremic syndrome. Patient will have fever, Neurological sign, thrombocytopenia, hemolytic anemia, and the renal failure. So if we get back here, the patient has the, where is the fever? Is there any fever here? Fever is a patient here. Okay. But it can be explained with leukocytosis. Here is features of hemolysis, thrombocytopenia, renal impairment, and fever can be explained by the leukocytosis. So the most likely diagnosis here is the thrombotic thrombocytopenic purpura, and the most likely organism here should be the E. coli infection. What is the presentation of a mycoplasma infection? Mycoplasma, anyone?
Atypical pneumonia with SIAD.
Yes.
Target lesion. There will be target lesions.
Mycoplasma will have the target lesion. No, I think the Legionella. Legionella is associated with the features of SIADH. Does mycoplasma comes up with the features of SIADH?
Legionella
Yes, sir.
hyponatremia, not mycoplasma. It's pneumonia.
It should be the
Yeah.
Legionella. Okay, the Legionella will come up with the features of hyponatremia, and the patient will have diarrhea, confusion, and this is associated with the air conditioning. Let me show you. Sorry.
Convention centers.
Yeah,
They have
convention.
mentioned the convention center.
This is the Legionella. The spelling of Legionella.
LEG.
Legionella should be in the respiratory medicine, or is it in the nephrology? Okay, I'll show you another thing. Okay, look at here. This slide is very important. The Streptococcus pneumonia, this is the commonest cause of the community acquired pneumonia, and this often has the classical presentation of rapid onset, high fever, pleuritic chest pain. And the patient will have the neutrophilia, and patient will have the normal CD4 count. And there is one condition when there will be low CD4 count, it occurs in case of pneumocystitis gyrophacy pneumonia, or in case of PCP, and the patient will have the low CD4 count, and if the CD4 count falls below 200, we'll have to give prophylaxis with the cotrimoxazole. So Streptococcus pneumonia, this comes up with the lower pneumonia, often associated with the herpes simplex infection, and the reactivation of the herpes simplex infection will be indicated by the cold sore. So if in the question the cold sore is mentioned, and afterwards the patient developed the pneumonia, the most likely organism is the Streptococcus pneumonia. Streptococcus pneumonia also come up with the Rostis sputum. Haemophilus influenzae pneumonia, this is associated with the COPD exacerbation, and this is the commonest organism for the acute epiglottitis. So both for COPD exacerbation and acute epiglottitis, Haemophilus influenzae is the commonest organism. Staph aureus and Klebsiella, both of them will come up with the cavitating lung lesions. So how will we differentiate between them? So Klebsiella K means alcohol. So Klebsiella will have the history of alcoholism or alcoholism, and patient might have the impairment. There will be neutrophilia, and A for aureus and A for abscess. So aureus will have the abscess cavity, and often the patient comes after the post-viral infection like post influenza or flu-like symptoms. So cavitating lung lesion plus A for aureus, A for abscess. The organism should be Staph aureus, and cavitating lung lesion with features of alcohol or alcohol. This occurs due to the Klebsiella pneumonia and often the
In diabetics also.
yes, also in case of diabetic patient and also in case of elderly patient. Mycoplasma will have the target lesion. This target lesion is known as the erythema multiforme. Chlamydia pneumonia. This is the organism for the atypical pneumonia. Patient will have either flu-like symptoms or the pleuritic chest pain, but the classical in the classical history, the keeping the bird like the pigeons will be mentioned, and the legionella. This is associated with the air conditioning system. This usually comes up with the hyponatremia and sometimes with the some sort of liver or renal impairment. And the treatment of Legionella should be azithromycin and levofloxacin. So A for azithromycin, L for levofloxacin. So E. coli infection closer to the thrombotic thrombocytopenic purpura, as the underlying diagnosis includes the patient's job in preparing vegetarian food, a large outbreak of E. coli related TTP occurring from the contaminated bean sprout, the fact that she has abdominal pain and vomiting, and there is confusion along with the microangiopathic hemolytic anemia picture accompanied by low platelet and renal impairment on laboratory testing. Plasma exchange, glucocorticoid, and rituximab are all the potential intervention. Antibiotics are ineffective. And the Shigella will comes up with the bloody diet, and this usually occurs in the child daycare in the epidemic form. Okay, next one.
Which of the following is the most likely cause of his abdominal mass? Acute pancreatic necrosis, pancreatic pseudocyst, pseudoaneurysm, retroperitoneal hemorrhage, splanchnic venous thrombosis. You are asked to review a 55-year-old man with acute pancreatitis who has deteriorated on the intensive care unit. He has developed a tender epigastric mass and a worsening of acidosis, hypocalcemia, and hyperglycemia. His blood pressure is 95 by 70 millimeters of mercury, and his pulse is 95 beats per minute and regular. His temperature is 38.2 degrees centigrade. Investigations: hemoglobin 9.1 gram, white cell count 15.2, platelets 123, sodium 143, potassium 5, creatinine 195, calcium 2.1, bicarbonate 12, and glucose 29 millimoles. Likely cause of his abdominal mass.
So this patient already has the history of the acute pancreatitis and now has come up with the features of acidosis, hypocalcemia, hyperglycemia with hypotension, with the features of shock. So there is low hemoglobin, leukocytosis. There is renal impairment here. There is hypocalcemia, and hypocalcemia always indicates the severe pancreatitis. And this is also evidenced by the elevated glucose level. Most probably the pancreatic beta cell has been severely disrupted. There is also metabolic acidosis. So what should be the most likely cause is abdominal mass.
Acute pancreatitis. Acute pancreatitis is a marker of severity of pancreatitis.
The acute, all the laboratory parameters and the clinical scenario can be explained with the help of acute pancreatic necrosis. And pancreatic cirrhosis, this is a chronic condition. The patient will come up with the abdominal mass, and then the patient usually doesn't have this type of scenario like hypocalcemia, elevated glucose level, or the features of shock. The pseudoaneurysm, the pseudoaneurysm can occur in case of acute pancreatitis, and this pseudoaneurysm is also associated with the abdominal mass, but the patient won't present with the features of hemolysis, leukocytosis, or hypocalcemia or metabolic acidosis. All of these features will be absent in case of pseudoaneurysm. In case of grade 2 peritoneal hemorrhage, the patient will have the classical back pain, but the back pain is absent here. And the splanchnic venous thrombosis. Splanchnic venous thrombosis can only occur in the presence of either gastric or the esophageal varices, or there should be history of the variceal bleeding, but there is no history of variceal bleeding. There is no history of the gastric or esophageal varices. So it can be the splanchnic venous thrombosis, and everything can be explained by using the acute pancreatic necrosis. And this necrosis has caused the elevated glucose level, and with the severe metabolic acidosis, and also some sort of renal impairment and the hypocalcemia. The hypocalcemia is a marker of severe pancreatitis.
How do you differentiate it from pseudocyst?
Sorry, again, please.
How do you differentiate it from pseudocyst?
The pancreatic pseudocyst is a chronic condition. The patient will only have the non-specific abdominal pain, and on palpation you will get the abdominal mass, but none of the serious features like hypocalcemia, elevated glucose with low bicarbonate, or some sort of hemolysis or leukocytosis, all of them will be absent in case of pancreatic pseudocyst. Just remember, pancreatic pseudocyst is a chronic condition, so all the features of acute presentation would be absent in case of pseudocyst. But acute pancreatitis or acute pancreatic necrosis is an acute condition, so all the features of acute inflammation as well as the acute deteriorating condition will be present in acute pancreatic necrosis. Pancreatic pseudocyst will only have the non-specific abdominal pain along with the palpable abdominal mass. The deterioration with evidence of a further decrease in pancreatic endocrine function, hyperglycemia combined with worsening hypocalcemia, acidosis, and an abdominal collection suggests acute pancreatic necrosis. Necrosis commonly involves both the pancreas and peripancreatic tissue. Secondary infection can also occur, which is usually gut-derived bacteria and is polymicrobial. So if the secondary infection occurs, what should be the choice of antibiotics here? For gut-derived bacteria, okay, I'm giving you the rule of the thumb. Any infection that occurs in the superficial parts of the body, most of the organism are the gram positive. As we go deeper into our body surface, meaning the abdominal cavity, most of the organism would be the gram negative. So more superficial, most of the organism are the gram positive. More we go deeper into our body structure, most of the organism would be gram negative. So most of the gut-derived bacteria would be gram negative. So we would go either with the third generation cephalosporin or the fourth generation cephalosporin. And the first generation cephalosporin has the highest gram positive activity. As we advances from first generation towards the fourth generation, the gram positive activity will gradually decrease and the gram negative activity of the antibiotics will gradually increase. For this reason, for the gram positive, in order to give coverage for the gram positive organism, we usually choose the first generation cephalosporin, and to give coverage against the gram negative organism, we usually choose the third generation or the fourth generation cephalosporin. So as the generation of the cephalosporin advances, the activity against the gram negative organism will increase and activity against the gram positive organism will be decreased. This is the rule of thumb. Okay, next one.
Which of the following is the most likely diagnosis? Malignant myeloma, membranous nephropathy, monoclonal gammopathy of unknown significance, prostatic carcinoma, transthyretin amyloidosis, TTR. A 72-year-old man is referred to the hematology clinic after presenting to his general practitioner with tiredness, night sweats, and gradually increasing lumbar spine pain. He has chronic obstructive pulmonary disease and a previous inferior myocardial infarction, but is otherwise well. His blood pressure is 139/80 and pulse is 80 beats per minute and regular. His body mass index is 22 kilogram per meter square and he has pain over the lumbar vertebrae on palpation. Investigations: hemoglobin 10.3, white cell count 6.9, platelets 152, sodium 143, potassium 4.9, creatinine 189, calcium 2.3, total protein 85, albumin 38, and urine protein 2 plus. Most likely diagnosis.
What's the diagnosis here? Anyone? Features of crab. All the features
It
of
looks
crab.
it looks like the feature of crab, except that calcium seems to be in the normal range.
Yeah, exactly. What does crab indicates?
Hypocalcemia, renal
No,
impairment.
it's the hypercalcemia. It's not the hypocalcemia.
Yeah. Hypercalcemia, renal impairment, anemia, and bone pain.
So the features of crab. So there will be hypercalcemia, renal failure, anemia with or without thrombocytopenia, and there will be either bone fracture or the osteolytic lesion. And in most of the cases of the multiple myeloma, there will be hypercalcemia. Yeah, but in some cases, in few cases, there may be normal calcium level. So here is the bone pain. So C is absent here, but R for renal impairment. Renal impairment is there. Then A for anemia, and B for bone pain. So among the crab features, all the three is present here. So the most likely diagnosis here is the malignant melanoma or the multiple myeloma. And in case of membranous nephropathy, the patient will have the massive proteinuria and there will be hypoalbuminemia. But here the albumin level is normal. Monoclonal gammopathy of unknown significant MGUS. This is associated with the IgM paraprotein level, and the IgM paraprotein level should be less than 30 gram per liter, and there should be no features of organ damage. But here there is features of the organ damage, and there is another condition which is the brother of the MGUS. That's the Waldenström macroglobulinemia. In that case, the IgM paraprotein level should be greater than 30. There should be evidence of renal impairment and the patient will have the features of hyperviscosity. And let me show you another thing regarding the multiple myeloma. So in case of multiple myeloma, also known as the light chain deposition disease, there will be anemia, hypercalcemia, renal failure, bone or back pain, and there will be hypercalcemia. And sometimes pancytopenia may also be present. And this one is very important. In case of multiple myeloma, the total protein will be increased, but the albumin level will be normal. And we know that the globulin is calculated as total protein minus albumin is equal to globulin. So if the total protein is increased, albumin remains normal. So the globulin level will be increased. So there will be increased immunoglobulin fraction or increased globulin level in case of multiple myeloma. So in case of multiple myeloma, there will be elevated total protein level, but there will be normal albumin, which will give rise to the increased immunoglobulin fraction. And on dipstick testing, we'll get the Paynes-Jones protein, and Paynes-Jones protein is specific for multiple myeloma. So we are getting both hypercalcemia and hyperkalemia. So just look at here. The albumin level is normal here, but the total protein has increased here. So total protein minus albumin, meaning this patient has the raised globulin or the raised immunoglobulin fraction. Okay, last one.
Which of the following is the best way to assess her level of hepatitis B immunity? anti-hepatitis B core antibody level, anti-hepatitis B surface antibody level, hepatitis B E antigen level, hepatitis B surface antigen level, hepatitis B deoxyribonucleic acid level. A 29-year-old nurse is reviewed in the emergency department following a needle stick injury from an intravenous drug abuser who is known to be a hepatitis B carrier. The nurse has been vaccinated against the hepatitis B and is known to have never been infected with the virus. Best way to assess her level of hepatitis B immunity.
So how do we assess the level of immunity in hepatitis B? Anyone?
Anti-hepatitis.
Yes, very good. We'll have to go with the anti-hepatitis B surface antibody level. Can anyone tell me the interpretation?
It's below 10. So below 10, the patient needs to be revaccinated. 10 to 100 only booster dose, and above 100 is a good responder.
Yes, excellent. So after giving the full dose of vaccination to a patient, giving the vaccination for against the hepatitis, we'll have to measure the anti-ASBS. And if the level is greater than 100, this indicates the adequate response and no further testing will be required, and booster dose should be given at or after 5 years. So greater than 100, adequate response, no further testing required, just give the booster dose. If the level is in between 10 to 100, this indicates suboptimal response, and also no further testing is required. Give additional vaccine dose followed by the booster dose at 5 years. So when the level is greater or equal to 10, then no further testing is required. If the level is in between 10 to 100, just give the one additional vaccination followed by the booster dose after 5 years. And if the level is greater than 100, this indicates the adequate response, and you will have to give the booster dose after 5 years, and less than 10 indicates the non-responder, and testing is required, and based on the testing we'll have to decide if every patient should receive the further 3 full vaccine dose with or without HB IgG immunoglobulin. Now let's see which patient should be given HB IgG and which patient shouldn't. So we measure the anti-ASBS level. The level is less than 10, and this falls under the category of the non-responder. So we'll have to test for current or past illness, and after that we'll have to give the full vaccination course. And after giving the full vaccination course, meaning after giving the 3 vaccination course, we'll again measure the anti-ASBS. Still, if the level is less than 10, then we'll have to give the immunoglobulin. But if the level is greater than 10, then for greater than 10, if it is greater than 10, then we'll follow this parameter. If this is greater than 100, we'll follow this parameter. But still, if this is less than 10, then we'll have to give the immunoglobulin. So I think we have concluded today. So we have only discussed only probably around 25 to 26 questions, and I will try to cover at least 50 questions from next day. Okay, thank you everyone.
Thank you, sir.
Doctor, which paper are discussing tomorrow?
January 2020. January 10th.
Okay.
Okay, thank you everyone.
Thank you.